This is the part 3 of FIGO Cervix guideline Embrace 1. That is evaluation of MRI based brachytherapy in locally advanced cervix. So till now we know that in locally advanced cervix management is external beam radiotherapy followed by intracavitary brachytherapy. So intracavitary brachytherapy is given according to point A dosage system. So this was older. New is preferred that MRI based, that is image guided adaptive brachytherapy is preferred as it improves local control, survival and better toxicity profiles. Embrace 1 study shows that feasibility and efficacy of MRI based image guided adaptive brachytherapy in the treatment of local advanced cervix. A personalized target delineation and organ at risk contouring followed by dose optimization and tailored multiparametric dose prescription. High rate of local control when compared to the previous historical series that utilized point A based brachytherapy with 5-year local control of 92%. So MRI guided brachytherapy shows better result than the old tradition point A based brachytherapy. Embrace 1 also investigated treatment related late morbidity and patient reported outcomes. So the grade 3 to 5 morbidity incidence is lower when using MRI based brachytherapy. Complications like genitourinary events, gastrointestinal event, vaginal event and fistula. This morbidity rate is less in MRI based brachytherapy. Standard intracavitary radiotherapy by using a tandem and two ovoids, a tandem and ring. Any of those dose rate system, namely low dose rate, high dose rate or pulse dose rate. All three had comparable survival rate, but high dose rate is preferred. Low dose rate or pulse dose rate is not preferred. Low dose rate system, dose of 30 to 40 gray, 1 or 2 sessions. But this emits radioactive material isolated when low dose rate is given. SDR is preferred, usually 3 dose, each dose having 7 gray and weekly basis. Fraction is given. So delivering 3 instead of 5 fraction is more realistic and allows for treatment of a higher number of patients. And EBRT plus ICRT range is 80 to 90 gray. PDR rarely used. Interstitial brachytherapy. ICRT is not feasible. That is intracavitary radiotherapy is not feasible due to distorted anatomy or inadequate dosimetry. And interstitial brachytherapy is preferred. Inserting multiple needles or catheters into the primary tumor and parametria through the perineum with the help of a template. So this is the template and these are multiple nodules. So this point used to fix to the skin of the patient, and you must use ultrasound, especially transrectal ultrasound during the implant procedure to avoid the risk of trauma to normal structure like bowel and bladder. This is the image of interstitial brachytherapy implant. This is the clinical image and this is the CT image. Completion of radiotherapy protocol. If the treatment delays, then the outcome worsens. So target is to complete the therapy within 8 weeks. And if exceeds more than that, then there is high rate of pelvic failure. Outback study. This is a negative trial. Role of additional adjuvant carboplatin and paclitaxel chemotherapy after standard cisplatin based chemoradiotherapy for unselected leg, that is for locally advanced cervix. If after EBRT and ICVT, if you give adjuvant chemotherapy, then it shows no improved overall survival and also increased short-term toxicity. So not to give adjuvant chemotherapy after completion of radiotherapy. Outback study is a negative trial. Interlace trial, that is use of hot course induction chemotherapy followed within 7 days by chemoradiation to enhance treatment outcomes in locally advanced cervix. Short course induction chemotherapy to give paclitaxel plus carboplatin. paclitaxel dose is 80 mg per meter square and carboplatin is area under the curve 2, that is 4 dose to give, followed by to give radiotherapy, that is EBRT plus ICBT. This short course induction chemotherapy optimizes tumor response by reducing tumor burden and eradicating micrometastatic disease, thereby improving long-term disease control and patient survival. Interlace trial shows short course induction chemotherapy is good. Immunotherapy in locally advanced cancer. Keynote A18 study shows that addition of pembrolizumab along with radiotherapy improves the period-free survival. Similarly, Nicole trial shows that nivolumab concurrently with chemoradiotherapy increases the safety and tolerability. Other trial immune checkpoint inhibitor are Keynote 826, Gala trial, PDCC, Vanguard CX11, GOG 3047, Keynote A18. All shows that immune checkpoint inhibitor is the first-line standard therapy for patients with recurrent or advanced cervical cancer. In stage 4B or distant metastasis, concurrent chemoradiation may have a better response than systemic chemotherapy. So concurrent chemoradiation is given. No rule for prophylactic extended field radiotherapy in lag. When paraodic nodes are involved, then only extended field radiotherapy with concurrent chemotherapy should be used, and intensity modulated radiotherapy to use in such patients to reduce the toxicity. Distant metastatic disease. Despite limited response rate, cisplatin is the standard chemotherapy, and use of platinum doublets over cisplatin alone, although with very modest benefit in response rate. So cisplatin may be combined with taxane, topotecan, 5-fluorouracil, gemcitabine or vinorelbine. Paclitaxel carboplatin combination has also been successful in these cases. And in advanced metastatic and recurrent cervical cancer, immunotherapy shows survival benefit. After inadvertent incomplete surgery, so subsequent therapy is required in such cases. You have to know the extent of disease. For that assessment, you can do PET CT scan if available. Otherwise, CT scan or MRI and chest imaging to do. And the further treatment is based on histologic and radiologic findings. Although post-operative radiotherapy has shown beneficial, the overall response rate is not good. So, POT does not compensate for lack of adequate surgery. In centers where expertise is available, repeat laparotomy with parametrectomy and pelvic lymphadenectomy the procedure to do. Post-treatment follow-up. Median time recurrence is 7 to 36 months after primary treatment. So close clinical follow-up in the first 2 to 3 years after treatment. Every 3 to 4 months in the first 2 to 3 years. Then 6 monthly until 5 years, and then annually for lifelong. At each visit, you have to take history properly and clinical examination to detect treatment complication and psychosexual morbidity. Also to assess for recurrent disease. Routine imaging is not needed. Involved high pelvic lymph nodes justify the interval imaging of the abdomen to assess for potentially curable progression of disease. If asymptomatic recurrent disease, physical examination is the best to detect the asymptomatic recurrent disease, followed by chest X-ray, followed by CT scan, and last is the vaginal vault cytology. So frequent vaginal vault cytology does not significantly improve the detection of early disease recurrence. Under 50 years who have lost ovarian function can be considered menopausal hormone therapy, but adenocarcinoma with HPV independent tumor not to give menopausal hormone therapy. Recurrent disease. Most recurrent site is locally in the pelvis. Next is paraortic lymph node or distant metastasis can occur. So risk of both pelvic and distant failure increases in proportion to the tumor volume. If tumor volume increases, then there is risk of failure, and most recurrences occur within 3 years. Prognosis is poor. Most patients die from progressive disease, with uremia being the most common terminal event. So treatment plan depends patient's performance status, site of recurrence, extent of recurrence, and metastasis along with prior treatment received. Always you have to do biopsy for the confirmation of recurrence. Most common site of recurrence is pelvis, and good prognostic factor is the presence of isolated central pelvic recurrence with no involvement of pelvic sidewall, a long disease-free interval from previous therapy, and the largest diameter of the recurrent tumor less than 3 cm. If pelvic relapse follows primary surgery, then radical chemoradiation or pelvic excision to do. Radical irradiation with or without concurrent chemotherapy may result in 5-year disease-free survival rates in the range of 45 to 74% with isolated pelvic failure after primary surgery. The extent of recurrent disease and involvement of pelvic lymph node are prognostic factors for survival. Concurrent chemotherapy with either cisplatin or 5-fluorouracil may improve the outcome. Pelvic excision. If no evidence of intraperitoneal or extrapelvic spread, there is clear tumor-free space between recurrent disease and the pelvic sidewall, then you can do pelvic excision. But remember that this is high morbidity surgery. Before that, you have to do PET CT scan to determine any sites of distant disease and before excision if possible. Patient assessment and counseling to manage stoma and ostomy sites must be done before surgery. Remember, overall survival is just 10%. But careful selection of patients have been reported to yield a 5-year survival with pelvic excision around 30 to 60%. Para-aortic nodal recurrence. This is the second most common site of recurrence after pelvic. Isolated para-aortic nodal recurrence. Curative intent radiation therapy you can give or chemoradiation therapy you can give. Long-term survival in approximately 30% of cases. Extensive local disease or distant meds. So palliative therapy with best supportive care to give. When patient with ECOG status of 0 to 2 and only limited metastatic disease, then palliative systemic chemotherapy to give. Where feasible, these patients could be offered participation in clinical trials, especially when the interval to relapse is less than 12 months. GOG 240 trial, it shows trial of platinum doublet chemotherapy along with bevacizumab. So bevacizumab we know is a humanized anti-VEGF monoclonal antibody. It is used in treatment of recurrent and metastatic cervical cancer, and it shows increased overall survival. But the drawback is it is expensive and limited benefit in terms of response rate and period-free survival, and its side effect is the hypertension, thromboembolic events and GI fistula. Keynote 826 randomized to receive pembrolizumab versus placebo in addition to platinum based chemotherapy, and it shows that pembrolizumab group improves PFS and OS. But remember the side effect of pembrolizumab, that is anemia and neutropenia. Empower cervical 1 semiplimab in recurrent cervical cancer. Another immune checkpoint inhibitor used in cervical cancer is the tisotumab vedotin. Comprehensive palliative care. Common symptoms and signs of advanced cervical cancer include pain, ureteric obstruction causing renal failure, hemorrhage, malodorous vaginal discharge, lymphedema and fistula. Palliative radiotherapy, that is short course radiotherapy at the dose of 20 gray in 5 fraction over 1 week or 30 gray in 10 fraction over 2 weeks. Fast use is severe vaginal bleeding. A short course of EBRT. If it fails, then intracavitary radiotherapy can be given, and control of bleeding is usually achieved after 12 to 48 hours of radiotherapy. Second is pain. Pain arising from enlarged para-aortic node or enlarged supraclavicular node or skeletal metastasis or cerebral metastasis, then palliative RT is given. Cervical cancer during pregnancy. Same principle as non-pregnant patient. Before 16 to 20 weeks, treat the patient without delay. The mode of therapy can be either surgery or chemoradiation, but it depends upon the stage of the disease. And you have to explain that radiation results in spontaneous abortion of the conceptus. But from the late second trimester onwards, surgery and chemotherapy can be used in selected cases while preserving the pregnancy. When the diagnosis is made after 20 weeks, delaying definitive treatment is a valid option for stage 1A2, 1B1 and 1B2, and has not been shown to have any negative impact on the prognosis compared with non-pregnant patient. And the time of delivery requires a balance between maternal and fetal health interest. When delivered at a tertiary center with appropriate neonatal care, delivery by classical cesarean section and radical hysterectomy at the same time to be undertaken, and the POG must be 34 weeks of gestation. For more advanced diseases, the impact of treatment delay on survival is not known. NACT may be administered to prevent disease progression in women with lac when a treatment delay is planned. Thank you.